I could definitely see a gap in the process of prescribing. So I was finding I was advising the newer, less experienced doctors about prescribing medicine, suitability for patients, obviously knowing the patients quite well as well, and often assisting with the prescriptions, making changes and making suggestions. And as part of that there was a delay in the process because I was having to run around and look for a doctor to write the prescription for my clinical decision, and clearly I had the backing of the doctors to make that based on my experience, but it was just that the process ended up being long-winded. So I felt if I could prescribe myself safely within my competence level, that would be overall a better experience for patients.
Yeah, I think obviously writing a prescription or is a culmination of a full and thorough assessment that involves asking lots of questions and doing a physical examination. In some cases, might be doing investigations, like we might request blood tests or X-rays. So I think there's almost an expectation of the patient. If you get to the end of that and say, well, actually no, I need to get a doctor to write a prescription for something, then I think they found that a little bit odd.
The patients love it. The patients love they like the one-stop shop. They like to be able to phone, someone come out to them and someone to prescribe and get it all sorted. And we have more of the actual other feedback of patients when I have members of staff who aren't prescribers go out. The patients are a bit disappointed. They do get confused as to why some people can prescribe and others can't prescribe, but yes, they really love it.
I think it enables the musculoskeletal care to become more of a one-stop shop scenario, so that when GPs refer someone, we can look after them essentially with all aspects of care, without having to go back and set up yet another scheme. Supplementary prescribing like that didn't really work. It was too cumbersome in musculoskeletal physiotherapy.
The benefits of prescribing to our patient group is that admission avoidance, because the team was originally set up because of lack of access to GPs. The team then came into post to be that advocate for the patient so they get prompt treatment. And having had prescribers in the team, obviously I know that them prescribing, the patient gets the treatment a lot quicker, other than us having to liaise with the GP and the GP processes, which are prolonged sometimes.
As a result of doing
Yes.
this, of me hopefully converting to an independent prescriber, we're setting in place a proposal to run an MSK painting, so that we can actually I'll run it as the independent prescriber, and we'll have physios and a technical instructor working with us, so there'll be 4 or 5 of us working explicitly within a dedicated clinic for people in chronic pain.
The pathway of care is much improved because we could be working with somebody in physiotherapy, 1 week, and if a problem arises around spasticity, we can make changes to their medicines management, there and then, or if we need to do any injections, then we can sort of, organise it from there instead of having to refer off, and then it takes a long time, and there's a lot of anxiety can build up about the wait and when things are going to happen. So we can, do that very quickly.
Non-medical prescribers are held to account to a much greater degree for any errors. So we will always work much closer to guidelines, much closer to evidence-based practice. And I think it might improve the evidence-based prescribing. There'll also be pressure on medical colleagues to follow suit. So I think for the patients it's actually a good thing.
Okay. I think it improves quality of care. As I say, I think it just gives the patient an extra choice of where to seek help from. Like we now have urgent care and A&E, etc., and walk-in centres. It allows our patients to either go to the GP if they're happy to go to the GP, or to come to us, and improving their pathway of care and speed of delivery of care.
communication and listening to what the patient's needs, you know, not just the assessment, but their understanding, you know, and letting them feel that they can talk to you and say, actually, my neighbour's had them and she didn't like them, you know. So rather than just take the prescription away and not filling it and not taking it, is making sure that they understand, you know, the problem and what you're trying to do, so that the treatment is more effective, because they're going to take the tablets that you give them.
Take what's been prescribed.
Take what's been prescribed for them.
And I think listening skills, because quite often we've got more time to spend with the patients, and they tell us things that they don't either have time, or that say a doctor or consultant flashes in and out, and they're a bit more in awe of them, whereas we're more approachable, I think. We're used to assessing the patients and in our heads knowing what the best thing, or thinking we know what the best thing for the patient is, and it's being able to take it to that next stage really as well.
Yeah. If you're doing all the assessment and the diagnosis and then you're not doing the treatment, that doesn't make logical sense. So that step,
it's that final last tick in the box, isn't it?
And then we can obviously, and we still do the monitoring. So even if it's prescribed by the GP, they don't go back to the GP. We'll be doing the monitoring anyway. So it's just that last little step.